Good day everyone, I'm Dr. Navrindranauth Rambaran. I have been tasked with looking at the Day 1 lectures for this TTT review. Now these lectures include the initial assessment and triage, the airway management, breathing and circulation, otherwise referred to as shock management, and finally, team approach to trauma. These lectures extend from 2.2 to 2.6 in the module. Now, in reviewing these lectures, I make the note that the trauma care standards have not changed in any paradigm way since the last edition of TTT. The approach in the opening lectures hold well for the expected level of care of the seriously injured patient, but there are a few opportunities for improvement, and these are the ones that I wish to share with you, and we can further discuss after the presentations. My first recommendation is that there be inclusion of permissive hypotension in penetrating torso injury until bleeding is controlled. I don't see any mention of direct compression of bleeding wounds, and this should be, I believe, in the figure below. And the use of tourniquet, though controversial, has its specific benefits in traumatic amputations and mangled limbs, and this is something I wish that we can discuss to see if it's included. Most of the recommendations for inclusion of content comes in the circulatory management, and this is true because this is the area of constant review and updates. Having said this, most of the general principles that are embodied within the TTT protocols for the management of the circulatory system are pretty much in order. Now, a second recommendation is that of nomenclature changes. There's at least one I saw that need to be included, and that is the use of the term subcutaneous emphysema in addition to check for air in the tissue. Third recommendation is that for improvement of procedures and illustrated figures. I believe that there are some technical improvements necessary, and this could be highlighted in the example of the needle decompression for pneumothoraces. It must be stated that this is done for suspected tension pneumothorax. I don't think it's actually stated, and it is effective in the second intercostal mid-clavicular line. If we look at the diagram below, however, I think it illustrates an area on the lateral chest wall which does not correspond to the second intercostal mid-clavicular line. One further recommendation to this end is the pericardiocentesis illustration, where the needle seems to be pointed towards the right, and just as a technical issue in the procedure, at least as a subxiphoid approach, the needle is actually pointed towards the left shoulder. So this is something that can be correct. Fourth recommendation after review is the possible inclusion of some investigative adjuncts to the primary survey. For example, chest x-rays and ultrasound or fast scan. I know TTT has stayed away from including these, but noting that some settings considered low resource that use TTT standards have such adjuncts available in their ERs. And this is quite true for the GPHC in Guyana, our ER that uses TTT protocols, and we do have a fast scan done for our trauma patients, and there's a availability of a early chest x-ray for these patients also. So I think that we really need to consider including these as adjuncts in the primary survey. The fifth and final recommendation that I have is to possibly emphasize specific potential complications of the employed interventions. I searched the interventions in the lectures for these, and I don't see a lot of them, but we know that interventions are not without their potential complications, and one example of this is a guard against C-collar soft tissue trauma and ulceration, and should be emphasized that providers should guard against too tightly fitted or prolonged C-collar use. As I said, the majority of content and its arrangement within these lectures are pretty much on point, and these are just a few recommendations in my review that I think could be used to improve these lectures. Thank you very much.